Welcome to Healthline 3. I'm Terri Simmons. Today we're talking with Dr. Ricky Paul of Willis-Knighton Pierremont OB-GYN Specialists. We're talking about cervical cancer screening, and we'll be taking your calls throughout the show. And as a reminder, please make sure you're in a quiet room with your TV turned down to a very low volume when you call in so Dr. Paul can hear your questions. And the number to call is 318-219-4569, and you'll see it across the bottom of your screen throughout the show. So Dr. Paul, thank you so much for being here today.
Thanks for having me.
So we're going to be talking about cervical cancer screening. So you want to start off and just kind of tell us what that's about, what that means?
Yeah, cervical cancer screening is a tool that we have to detect pre-cancer changes of the cervix. Everybody's heard of the Pap Smear. You know, we've been doing that for many, many years, and it's a very effective tool in detecting pre-cancer changes so we can treat them before they turn into cancer. The important thing to know about the Pap Smear is it just tells us about the cells on the cervix. It doesn't tell us anything about the ovaries or anything else. I think people get confused with that about the Pap Smear. But basically what it is a brush that we take and we brush cells off the cervix and we send it to the pathologist. They spread the cells out on a slide, so to speak, and look at it with a microscope, and they can detect abnormal appearing cells. And that's where we get our Pap Smear results, the abnormalities that we make our decisions on. Other testing as we've been doing now is what we call high-risk HPV testing. HPV stands for human papillomavirus, and we know that that virus is the virus that causes most all of the abnormal changes, precancer changes, and cervical cancer of the cervix, as well as other cancers too, but we're going to talk about the cervix today. So this is a test that we combined with the Pap Smear at certain ages to make it a very effective testing modality.
And is there a certain age that someone should start testing for that?
Routine screening is recommended at age 21. There are different intervals of screening. At age 21, if you are not in a high-risk groups being having an immunosuppressive disorder like HIV or solid organ transplant that puts you at risk for developing disease faster, or having abnormal Pap Smears before, then you should get a Pap Smear at least once every 3 years. At age 30, we recommend adding that high-risk HPV test to that Pap test. Now the experts say with that in the routine screening every 5 years is okay, but we find that a lot of people will fall into a higher risk group. So when they say 5 years, that's not for everybody. That's just for routine screening, people who haven't had abnormal Pap Smears or precancer changes before. We'll screen up to the age of 65. And again, 65 is the age that they say, well, you don't need a Pap Smear anymore. But again, that's not for everybody. That's only for people who've had adequate screening and who don't have any high-risk criteria. Another common question is, if I've had a hysterectomy, do I need a Pap Smear anymore? And that's a very good question. It all depends on why you had your hysterectomy. If you had your hysterectomy because of what we call benign indications, abnormal bleeding, fibroids, pain, things like that, and you don't have a history of having cervical precancer, then yeah, you don't need them anymore. And the reason is because that virus that causes these abnormal changes loves to live in the cervix. Well, with a hysterectomy, most of them, we take the cervix out. So what you have left is the vaginal cuff. And you can get abnormalities of the vaginal cuff if you have that virus, but they're not as common and they usually don't progress to a higher degree into cancer. But if you've had severe cervical dysplasia, precancer is what we call dysplasia, then yeah, we still pap the cuff because you can get these abnormalities that can rarely lead to vaginal cancers.
So those are all things good to know. If you say you're going to a new doctor, you moved to a different area, you had a hysterectomy somewhere else, and I don't know, is there, first let's start with, you can have a hysterectomy where they leave the cervix.
You can.
Is there a reason that happens where it leaves, or is there a decision to take it or not to, or?
Well, that's a decision-making process, and there was a type of hysterectomy in the past. We usually don't do it anymore. It's called a supracervical hysterectomy, and it was done laparoscopically, and they had these things called morcellators, and they would go in and chew out the uterus but leave the cervix. We really don't do that anymore. The morcellators have been taken off the market for certain reasons, but so these you'll see still with the cervix, and it's important for the patient to know they still have their cervix, because they still have to undergo the same screening as if you still have your uterus, because that cervix, again, like I said, it's the cells on the cervix that we're looking at, and that's all.
So really good to know, because sometimes you don't know to ask
know.
those questions. You've had a hysterectomy,
Yeah.
and you think you're going to go in for a Pap smear. They might ask you, do you still have your cervix?
Yes.
And so you need to know that with your surgery.
When you get examined, the doctor's going to see that cervix, and they're going to know. But still, it's good for you to know that.
Yeah, good to know. All right, and so you've talked about the different modalities, other screenings. What else can we do to test?
Well, one of the things, and it's not necessarily testing, it's vaccines. Now, we have a very effective vaccine out, and it's a vaccine against that HPV, that virus that causes these abnormal cells and precancer changes in cancer. And it's been around, since around 2006 or so, and we recommend that children get it. It's most effective when they get it before they become sexually active, before they're exposed to that virus. So at about 11 years old, we start recommending, and most of the doctors, the pediatricians and the family doctors who take care of children will recommend that vaccine for children. Not only girls, but boys also.
Oh, really?
Because it's really a sexually transmitted virus. So it makes sense to give it to the boys also. So, because they'll transmit it to the girls if they haven't. And there's other things that can cause. It can actually increase a man's risk for penile cancer, this virus. So very important vaccine.
Very important. Are there any side effects or concerns that parents have had with giving this vaccine to their children?
Yeah, well, it's interesting you say that. Back when it came out, I was in Texas, I remember, and our governor tried to make it mandatory for everybody. And of course, if you try to make people do that, they don't want to do it.
Right.
Of course, we know a lot of that with the COVID vaccine now. But no, we've got a lot of experience with that vaccine. As far as side effects, local tenderness where the injection was, and pain, things like that. And these are mild and transient, and you can get that with all vaccines just about. But as far as long-term effects, long-term health issues, no, we don't really see that. Much more effective in treating precancer states, and not only that, but genital warts. Genital warts in women and men are caused by the HPV also. So this vaccine is very effective in helping prevent that, which is a very socially distressing thing, especially for young people.
Okay. And is this a one-time vaccine?
No, it's not. And again, it's an age-dependent thing.
Okay.
If you get the vaccine before age 15, then you can get a series of 2 shots. You get a shot, 6 months later you get the other one. After the age of 15, it's a series of 3 shots. You'll get one, 2 months later you get the second, and then 4 months after the second one you get the 3rd shot. So it is a series.
Okay. That's good to know, though, while we're talking about cervical cancer, that there's ways to prevent it. Are there other things, like is it related to diet and lifestyle at all?
Lifestyle, yes. Cigarette smoking, it seems to be bad for everything.
Yes.
But we do know that people who smoke, women who smoke, and they have cervical dysplasia, cervical cancer, it'll keep it persistent or help it progress. The smoking does. So that's one of the things we've seen that we recommend. Also, high-risk sexual behaviors, multiple sex partners. Your chances of being exposed to that virus are greater, and there are different subtypes of that virus, and there's some that we recognize are more predispose you more to develop the precancer states in cervical cancer.
And that's really interesting and a good point for you to bring up, that most people might not think of having multiple partners could lead to cervical cancer. That's a really interesting way to put it.
It's really one of the biggest risk factors.
Interesting. So when someone gets something back, a report that something is abnormal, there is something precancerous, what's the next step?
Well, the next step is to do something called a colposcopy in the office, and that's just like a prolonged Pap smear. I like to tell my patients, okay, this is a prolonged Pap smear. We're going to put a speculum in. I'm going to look at your cervix with a microscope. I'm going to put some chemicals on there, and if there's abnormal areas, they look different when you put those chemicals on there. We'll spray a little dead-end medicine and do some biopsies and send those to the pathologist. And those are where the pathologist sends a report back and says, yeah, there's some mild changes that's caused by the virus, or there's some severe changes that are caused by the virus, or there's cancer here already. And that's where we make our decision as far as treatment or not treatment. And that's changed over the years. If there's mild changes, we really don't treat that anymore, because we know that the majority of that goes away on its own in people who are immunocompetent, who have a normal immune system. So we just kind of watch those closely. But it's the ones that are more advanced that we do treat. Treatment modalities are multiple things. Most of the time now we excise the abnormal areas. We can do that in the office with a procedure called a LEAP. It's an electrified little loop. We deaden the cervix and we just shave out those abnormal cells. Send that to the pathologist. And what we're looking for in that report is, yeah, you took all the cells out and there's nothing worse than what we told you it was on the biopsy. And that's the treatment. And you follow the patient with repetitive Pap smears to make sure it doesn't recur. There's things we do in the operating room called a cervical conization. It's kind of a bigger biopsy. Sometimes we do that when we think that abnormal area may extend up into the cervix, or if it's a broad area and we'll have trouble getting all of it, then we may do that in the operating room. There's freezing the cervix. That can be done. We don't do that as much anymore. It's called cryocautery of the cervix for abnormal areas, just for the simple fact that you don't have a specimen to send to the pathologist then. It just kills those surface cells and you follow with a repeat Pap smear. So, that still can be done in some cases. Usually not the severe precancer. We usually always want to excise that, but some of the moderate, so to speak, that some people still do that, but mostly excision's the treatment.
Okay. And does it, and then do you ever, like, you do a Pap smear and you get in there and there's something that looks like it is already cancerous, and then, so what's the timing on this? You see you have an abnormal report back and you do all of these things. Is it something that someone should take care of right away? If someone is just like, this is too serious for me, I need to think about this is scary to me, what's the timing that we can take care of this? Well,
the funny thing about cervical cancer is the timing. It's a cancer that stays in a precancer state a good while usually. It takes a while for cervical cancer to come, of neglect, if the patient doesn't go in. And we're talking about years. Okay, so if they come in and they have an abnormality, now if there's a suspicion of cancer already, then that's a different thing. But for the precancer states, you always want to address it, as soon as you can. But if they say, I want to think about this for a couple of weeks or a month, then you're probably not going to miss anything by doing that. But it's something you don't want to let go on for 6 months, a year. You do want to get that taken care of, because you don't know how long it's been there if you've just seen the patient. Now, if they had a Pap smear the year before that was normal, and then now this Pap smear is abnormal, then you've got some time, but still, you don't want to let things linger. Yeah, so you get a note saying, hey, your Pap smear was abnormal, you need to call the office, and someone doesn't, and they just wait till next time. You don't know how long it's been there, like you said. Right. And you can't say, I got a year or two, I'm good, but so we try to keep up with those things. Those abnormal Pap smears, we keep up with, and the pathologists too. They'll send you a report. These are the abnormal Pap smears that you've had over the past, 6 months or a year, or whatever, and then we'll go back and make sure that we've had follow-up with all those patients. So it's kind of multiple checks and balances that we make sure, because it is a preventable disease. Yes, preventable. We hear cancer and sometimes we just get scared. And the biggest thing is, like everything, just communication. You get something back that's abnormal, go talk about it, even if you're, don't let it scare you. That's
why you have the test. It's precancerous, it's abnormal, it's just something to look at and talk about some more. So there's nothing hurts in calling and just asking all the questions. And I'm sure just come in with every question that you've got, right? Just be open to talk and ask everything you need to know.
Absolutely.
Yeah.
And it's such a common disease. I mean, that virus, HPV, I mean, you know, we suspect that probably 80% of the population is infected with that virus at some point in their life. It's that common.
That's interesting. I too remember when it came out, and that was a big thing, and vaccinations were a big thing to talk about, and parents had a lot to decide, and then all the questions came up about discussing about when a child becomes sexually active, and it was just a really big deal. But it's something actually to pay attention to when something comes up like that, especially when it's widespread and talked about. And you're there. That's what our doctors are for. If this comes up and we've just discovered it, go to your doctor, and chances are that's why you have your doctor. He knows how long it's probably been before it's announced. You knew probably, you know, there's things to look at that are happening that we need to pay attention to.
Right. Yeah. Very important. You know, people you tell them they have an abnormal Pap Smear, well, the first thing they think is, oh my gosh, I've got cervical cancer. But the majority of the time, that's not the case, especially if they've been current on their Pap Smear. So, you know, it's just I try to reassure them, you know, look, this is very, very common. We see it all the time, but it's something that we want to prevent from, you know, advancing.
Yeah. It's so nice to be able to catch it in time and just take care of it.
Yeah.
And are there any symptoms?
You know, not really until you get the cancer. So that's the bad thing.
Okay.
You know, these abnormal cells on the cervix, we really, until they get very far advanced or cancer even, then you'll start having things like abnormal bleeding, bleeding after sex, things like that. But before that, you really don't.
Okay.
That's why it's so important to get screened.
Yes. And we also like to, it's so hopeful to have these conversations too, so everyone to see there's really nothing to fear because you have all of these resources. And if something does get too far, you find out you do have cervical cancer, there's still things to do, right? What happens if something happens and it's not precancerous? I've been told I have cervical cancer. Then what do I do?
Well, sir, any kind of cancer, you know, and cervical cancer too, you know, early detection is the key. So let's say you have cancer already. We do the things, and you've got cervical cancer. Well, then treatment is the next thing, and that you want to do soon. You know, usually we refer you to GYN oncologists. They're the ones that treat the cervical cancer. But as far as cervical cancer treatment, it depends on how far advanced it is. Very early disease, you can be treated with usually a hysterectomy. If it's a little bit more advanced, there's different types of hysterectomies that people can get, like radical hysterectomies. That has to do with taking lymph nodes out and, you know, top part of the vagina. Very invasive kind of thing. Also, radiation is a big treatment, especially for more advanced cervical cancer, and that's going to, most of your cervical cancer is probably going to be treated with radiation because most of it that we catch is going to be a little bit more advanced. So it's a bad disease, you know. So the whole thing is, let's catch it before it's that cancer.
Right. And is cervical cancer like all cancers there? It can spread to other places? I mean, can you?
Yes.
Yeah.
It's a cancer that, you know, it'll spread usually locally into the uterus, out into what we call the perimetrium or beside the cervix, things like that. But yeah, you can have distant metastasis too. These cells can travel through the lymphatic channels or things like that and get in different places. They can show up in different places.
Okay.
Brain, you know.
Oh, really?
Oh, yeah. Just like the other cancer.
Just like any cancer.
Lungs, you know, they'll land in different places and grow there too. Yep.
And does it, and this might be a silly question, but can it go right to the brain? Does it have to travel and it will affect whatever it's closest to? Or is there some kind of cancer that will go right to the brain or right to the lungs? Or?
Well, there's different cancers have different predilection for different parts of the body, and some will metastasize a lot faster. Cervical cancer, you know, it can, but usually it's a locally, especially early on, it's going to be a local type cancer. Okay,
and this cervical cancer, like we're talking about today, mostly those places you talked about.
That's right.
Yeah. Okay. And you talked about different hysterectomies, and a radical one, like you talked about, involves what? Lymph nodes and just everything?
Yeah, you just take, you know, the uterus, which is the womb, the tubes, fallopian tubes, and the ovaries too. And then the cervix, of course, but then there's lymph nodes that drain lymphatic channels all in the pelvis, and those all come to. These lymph channels will kind of follow up the vessels in the pelvic sidewall and up into the aorta and things like too. And so they take those nodes out. And you basically try to get most of the tissue all the way out to the pelvic sidewall to get the bulk of the disease out. And that's the big thing with treatment, is removing most of the cancer all of it that you can, basically.
Right. And if a woman just says, can a woman decide that? Just take everything, even if it's not affected? Can she say, I would like to have, can she choose to have a radical hysterectomy, or is it best to just?
Well, usually not. I mean, it's a good conversation to have with the doctor. But if it's very limited disease, I mean, a lot of them will still do the lymph nodes, okay, the GYN oncologist. But you have to realize with these radical hysterectomies comes problems also. Lymphatic drainage problems, chronic swelling of the lower extremities. So it's a little different than a simple hysterectomy.
Right.
But that would be a conversation that you'd have with your doctor, which is important. You talked about talking with your doctor, and they could explain those things to you. Well, we could do this, but here are the risks of doing that. And here are the risks of not doing it. So, yeah.
And is there an advantage to leaving the cervix when you have hysterectomy? Leaving it there?
Yeah, if you don't have cervical disease, there are some maybe advantages. Some women think it affects their sexual function. We found in the studies that if your sexual function was fine before hysterectomy, even if you take the cervix, it's still going to be fine.
Okay.
Now, support of the vagina is a big thing with the cervix. A lot of the ligaments that support the vagina actually come into the cervix. And during a hysterectomy, if you cut those ligaments, then you can increase their chance of developing vaginal prolapse. There are ways that you can help prevent this, even if you take the cervix out. But that's one of the things to think about with that too. But again, we're pretty effective in making sure that vagina doesn't prolapse, so we really usually take the cervix out.
Okay.
Every now and then you'll have a woman that says, I don't want my cervix out, and we'll talk about it. And there's different ways of doing hysterectomies that to get it done, you have to take the cervix out through the vaginal route. That's the way you go. So you have to take the cervix out if you're going to do it that way.
Right.
It's most of the time now, these hysterectomies, if you're going to leave the cervix, you basically have to do the kind of the old cut the belly kind of thing, because we don't have these power morcellators anymore, because the uterus is bigger and we can't chew it out through these little ports, so to speak. It still can be done. You can make a little mini incision and do it, but it's a little bit more of an undertaking. So most of the time the cervix comes out.
Yeah. Okay. Is there any group of women that are more prone to get cervical cancer?
Again, it's an environmental cancer. A lot of women say, well, my mother had cervical cancer, so I'm at risk. Well, not so much, because we know it's because of the virus. So the group of women that we see it more in are women who have multiple sexual partners. That's the big risk factor. That virus, being exposure to that virus. Poor health, women who their immune system is not very good because of whatever reason, get exposed to the virus, then they're at higher risk. So it's not necessarily a type of person, race, things like that, but it's
lifestyle, environment.
Lifestyle, yeah.
Just paying attention once again.
Yeah, and anybody can get it.
Anybody.
That's the thing. Yeah. Sure enough.
Yeah.
And I'm sure there are genetic factors that make people more, susceptible to precancer changes that advance to cancer. But that's something that we don't know. We know it's genetics allows that to happen. It's like COVID, for instance. What makes people get sicker, and some people don't have any symptoms.
Right.
It's probably got something to do with the way their genetic makeup handles the inflammation that the virus causes, or something. But anyway, so it's different in everybody.
And is there any age that really?
Usually we're going to see these cervical cancers in the middle age, the 30s, in that area, because they get exposed. It's a precancer state, and most of the time we see it in women who they don't go to the doctor and get their annual screening. That's why it's so important. And then they'll come when they have symptoms, like we talked about, the abdominal bleeding. Well, then the cancer's already there, and usually that's where we see it, 30s, 40s. That middle-aged person.
They just get too busy, or just don't go, or I'm healthy, I'm fine, and I don't want to go get my Pap Smear, or I just don't want to go. I just don't. It's not something I want to go.
Right.
Do. Yeah. That just happens. Okay. So. We talked about too about going every 3 years. When did that change, or has it? That used to be every year you went, or if you were susceptible, like if you had something. I know that sometimes there's a condition a woman might have in her younger years or later where she goes every 6 months because they're watching something back in the day. Did that change, or is it some people go every year and some go 3?
Well, that's a great question. So you remember when I said that Pap Smear only tells us about abnormal cells on the cervix?
Yes.
That's doing a Pap Smear every 3 years or every 5 years.
Okay.
Doesn't have anything to do with going to do your annual exam every year. You still should do that because you have other things that can go wrong. Abnormalities of the ovary, bleeding abnormalities, and other screening things, So that's a confusing thing. And women say, well, I don't need my Pap Smear once every 3 years. She may be correct, but she probably still needs to go to the doctor because you'll miss stuff. Blood pressure checks, those are very important. High blood pressure, again, not really any symptoms from that. But left unattended, it causes damage to your organs, heart, brain, kidneys, those kind of things. So for that reason, it's important to go at your regular intervals. You just may not get screened with a Pap Smear every time if you're in that normal risk group. Sometimes we still come every 6 months or so, depending on abnormalities. If they've had a very, pre-cancer stage and you've done a procedure, sometimes we'll repeat that Pap Smear before a year to look for recurrence.
That is such a good point, and I'm so glad I asked, because I think growing up we don't know the terminology, and you think you're going to get, there is a difference in going to get your annual exam. There's more to it than the Pap Smear. It's the Pap Smear that you don't need every time.
That's
But still that yearly checkup, there's other things that happen during a Pap Smear.
Sure.
'Cause I remember it was always just like, you go get your Pap Smear. That was just what we called our annual exam. But that's not true.
Yeah, I mean, they'll come and, I examine them and I feel their neck and they'll have a thyroid nodule and I find a couple of thyroid cancers every year.
Wow.
It's kind of a weird thing. But, so it's important to go every year. And a lot of women say, well, I get my Pap Smear, that means my uterus and my ovaries and everything are fine. Well, the Pap Smear tells you nothing about your ovaries. Yeah, it's only that cervix, or the mouth of the womb, as people call it.
Yeah.
Yeah.
And so what are you looking for when you're examining the ovaries on just an annual visit?
Well, the ovaries is a field, so we call it a bimanual exam. We feel down below and see if we feel any enlargement of the ovaries. Of course, pain might elicit us to look with an ultrasound or something.
Okay. But still, those cervical cancer screenings, very, very important.
Very important.
Very important. What else would you like us to know about that?
Well, that vaccine, it's very effective, and getting it in the children when they're young is the key. We've just markedly reduced, and we're going to see as the years go on, as that vaccine's been out and more people get vaccinated, that the occurrence of cervical cancer and genital warts and everything is and it's already dropping just because of the vaccine. But if we can get a majority of the population vaccinated, we'll see this disease go down a lot.
And is it only to start in children and young teens, like an adult? If an adult hears about it and wants to start taking it,
they can.
Okay.
It's approved up to age 26. But even after that, women can get it. Just say they get divorced and they're going to get a new husband. Well, maybe they want to get the vaccine because then there's a chance they get exposed to the virus. So, yeah.
Okay. Yes, because what really constitutes multiple partners? It doesn't mean that you're terribly promiscuous and have a ton of them, too. It's you
if
remarry,
you've slept with one person in your life who slept with one other person, chances are you've been exposed to the virus.
Right. So it's really something to think about. It's nothing to have shame or blame or anything.
No.
That multiple doesn't mean being promiscuous out there. It just means more than one.
That's right.
Yeah. Okay,
Exactly.
something to pay attention to.
Exactly right.
Okay.
Yeah.
All right. And so we've learned so much. Thank you so much about screenings and exams, and we thank you so much for spending time here today. We really appreciate it.
Thanks for having me.
It's very important information, and I'm sure all of our viewers appreciate it too. So thank you for joining us for Healthline 3 today, and we'll see you next time. Take care.